All right. So, for those just tuning in, how are you? I'm Chet Donley. I'm a spine surgeon here in my hometown, Dallas, Texas. Today, I'm going to answer questions, go over different things, kind of a live setting to talk about things. In general, I'm going to try to focus a lot of our talk today on back pain, what causes back pain, because that's hard to get it better if you don't know the diagnosis. And try to talk a little bit about stenosis, the term stenosis, and then let's talk about some technology. And today, I think we'll focus a little bit on robotic spine surgery. Well, let's just get right to it. So, one thing is stenosis. For those at home that you don't maybe know if you have stenosis or not, but if you see that on an MRI report might use the word stenosis. Pretty much, it's a fancy medical word for squeezing of the nerve roots. So, if this is the spine, you kind of can get stenosis in two different areas in general. One, you get something called central stenosis. That's where if you're looking down the tunnel of the spine, so kind of right down this tunnel part right here, you can get squeezing of the central part. That's central stenosis. There's mild, moderate, or severe. And then these nerve tunnels on the side, you can get foraminal stenosis. Foraminal stenosis is when these nerve tunnels coming out, they can get squeezed. They're called the foramen. So there's kind of two different areas where you can get stenosis: central stenosis, foraminal stenosis. In terms of what causes that, well, there's a variety of reasons. In general, there's three different reasons why someone might get pinched nerves. Think of it that way. You can get a disc herniation pushing out that way. You can get arthritis in these joints here in the back called the facets. Those get arthritic, those rub. Those can then start squeezing either these nerves or centrally. You can start squeezing down in this area, causing central stenosis. You could get, I know I said there's three, but there's probably 20 things, but the other number three here is when you lose your disc height, that can come down, squeeze these nerves. Or you can get my favorite thing of spondylolisthesis. That's when one bone slides forward on the other, and that inherently can cause nerve tunnel squeezing and stenosis. So let's me kind of get some questions here. So can't read the name, but it goes across pretty quick, and it says, I have stenosis in my cervical spine, bone spur, herniated disc. Okay, I guess not really a question, just a comment. I have herniated disc L2, L3, and suggestion other than surgery. I've had PT and injections. Hard to say, can't give like true formal advice, but I would say look in general for issues at L2, L3, or anywhere else in the spine. The course of physical therapy, course of injections is definitely the mainstay treatment. If that's going to get better, well, you can always do it again. A little hard for me to kind of give too much advice just on that, but other things other than surgery could be aquatic therapy, traction, sometimes chiropractic therapies, helpful for very, very certain things. So other options still besides surgery, but it sounds like you've done two of the biggest mainstays of it. From person Vyas, VYAS, I had a discectomy, which my disc height had reduced in the new MRI. Is that normal? I had a discectomy after which my disc height had reduced on the new MRI. Is that normal? Probably. I'm just reading that out loud to think what that means. So if it goes bone, disc, bone, and you herniate some disc out, the doctor will go in there and just grab out that piece of disc material. So in terms of, do they go searching around through this disc space? No, not really. It's just that disc material that's already out. You don't really go searching through there. It's just kind of that disc material that's already out. So really, no. Is it normal for it to decrease? Well, the reason you had that disc come out in the first place is you lost some disc height here. As it comes down, it squeezes on that disc space. So the fact that you had a disc herniation already means you've already lost some of that disc height there. Someone's asking, not sure to say this. I had a Vertiflex procedure in 2023 to buy me time. Can you help me? Sure. I'm always happy to help, Nancy. Yeah, the Vertiflex isn't a reason I couldn't help someone. Another question from Stack. I went to a chiropractor. He told me I have an extra vertebrae or vertebral column. Well, that's like maybe true, maybe untrue. Sometimes it's just based on how we count in the spine, whether you count from the ribs down or the sacral spine up, because you could have one bone down here, the S1, where you have a rudimentary disc space that kind of it's like a fake disc space. So if you count from down there, if you have that, you might think that. From Stunna, I had L5S1 discectomy, gone for herniated disc 6 years ago. Will I ever have problems again? Probably. If you've had a disc herniation once, then that means you're genetically predisposed to having back issues. Two, it means maybe certain lifestyle things you've done in the past predisposed you to having back issues. Four or three, wherever I'm at now, you also have some maybe modifiable risk factors that you're doing that predispose you to it. And then four, you had some issue there. So could you have continued disc collapse and additional disc herniations at that level or other levels? Yes. Look, if it's been 6 years and you haven't had issues, that area is scarred in, it's healed in. It's not going to be causing your issues just from that now 6 years out. But maybe I saw another comment. Sorry, there's about 1,000 people on the different platforms that come in fast. Can you explain spondylosis? I am scared of surgery. They want to take out my L5 and fuse L4 to S1 from Daniela, 2 boys under 2. Oh my goodness, where do we start with that? So those at home, they're like, whoa, what did he just say? Yeah, that's a very complex diagnosis. Look, I just put up a video on spondylolisthesis on YouTube. It's about 30 minutes, and I actually talk about spondyloptosis, and I even show some papers that I've written on spondyloptosis. It's somewhat rare. It's not as common as the other grades, but what spondyloptosis is when it goes bone, disc, bone, and this bone is completely, I don't want to do it on this model because I don't want it to break, but be kind of like this, where that bone just is totally off. It's more than a grade 2, more than a grade 3, more than a grade 4. It's a grade 5. It's the bone's completely dislocated. Now, in general, it's somewhat of a congenital thing. You weren't 100% born with it, but there's certain anatomy factors, and it just got to that point really fast. In terms of what they want to do about it, there's about 5 or 6 different ways to fix that. Just reading from your comments there, usually the fusion is an L4 to S1 or an L4 to pelvis. You have to do a lot of correction there. So it's a big surgery, definitely scary, but really definitely something that if they're recommending doing it and you're having pretty poor activities of daily living, I would highly recommend listening to their advice on that. Okay. Got a couple people in here. One is from my good friend David. He says, I feel really, 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 really good, Doc. Thank you. We owe you. Of course, David, good to talk to you. Sorry, man, I got a little tickle in my throat. From Diego, he's 3 months post-op, 2-level ACDF, lots of soreness, still turning his head. Does that ever change? Yeah, usually 2 months out after a 2-level, even 3-level cervical surgery, you're feeling pretty darn good, but it's different for everyone. So if you're having little wear and tear pain here and there, that's not terribly uncommon. What do you look for in a spine rep from ML? You want someone that, I know some of these things are pretty obvious, but someone you can trust, someone that could be your friend, and someone that you could you could think about spending time with, because in a way you're spending, goodness, at least 20 hours with them a week. So that's number one. Most of them are going to be very knowledgeable. They wouldn't have made it to that point. So saying that they're smart is an obvious statement. They're going to have that. I think, goodness, I don't know if I'm going to be able to do this all day. I might have to go get a drink really quick. I think the best thing in a spine rep or any rep is that they've thought of plan B, C, and D when you haven't even maybe thought of it, or maybe the spine surgeon's thought of it. They just haven't voiced it to their rep. And what I mean by that, that's like in removal of hardware cases or deformity cases. The rep has the experience or has thought about the case themselves and aren't just showing up with the tray to fix that, but they have stuff in the trunk of their car or on the shelves, usually on the shelves, hopefully sterile, ready to go, if there is something that pops up that wasn't expected. So I think that would be the best thing you'd want in a spine rep, is that they've thought about other alternative plans to accomplish the goal that maybe the spine surgeon hasn't even initially thought of. So that's why it's having a good team. And, the reps are an important part of the surgery for sure. From one of my good friends, Sprinkles and Sunshine, can spinal stenosis cause pain along the inner leg from the groin to my calf on one side, no swelling? Definitely can. Usually if it's in the inner groin, that's an L2 or an L3 area. If it goes down the calf on the inside, that could be an L4 area for sure. If you Google spine dermatomes, you can see a map of where different nerves go in general. There's a lot of overlap though. From Amy, how common is it to experience a complication with a L5 discectomy? I was back in the OR 24 hours later. Uncommon, I'd say less than 5%. It depends on what the complication is. If you're back in the OR 24 hours later, I would also think of it as, I'm not trying to be defensive, but like commending the doctors, the nursing staff, and even yourself for recognizing a problem and getting you back there to fix it, as opposed to burying their head in the sand. So I don't know what your problem was. It could be if you had a discectomy. So there's no hardware. If you had a post-op hematoma, that's all I could kind of think about. What would be something you'd return to the OR 24 hours later after maybe a CSF leak? It'd be hard to know what your issue was, but good for you for noticing it and good for them for fixing it. So, things happen for sure. It's like you take your car to the shop and sometimes, rarely take it back and it's just not working right. And they're like, you know what, we thought we did our best, but maybe your car's something different or it was another issue on top of that. A little hard to say, a little hard to compare it to cars. I don't know anything about cars. Another thing here from Vias, VYAS. No, I don't, but my colleague, Dr. AJ Rush, does. And so usually I send people to him for evaluation of that condition. All right, let me answer a couple more questions here. Where am I? I'm in Dallas, Texas. I'm a spine surgeon here in Dallas, Texas. I usually jump on these. I haven't done this in a couple weeks, but usually on the weekends for about 20 or 30 minutes at a time, I record these on different platforms. I try to talk about different conditions. So someone else or some other conditions that cause back pain. One of the other back pain conditions is when the disc is so worn out, that can be a source of back pain. When the joints in the back, called the facets, have such severe arthritis, that could be a source of back pain. When you have scoliosis, and this isn't just the scoliosis where you're crooked like that, but if you have something called flat back, so your back, instead of being curved, make sure this works, curved like that, which is good. You want this curved lordosis. You could have a straight flat back, and this straight flat back causes you to bend your knees, bend your hips, trying to pull your back. If this is your skull, you don't want to be living your life like this, so you try to pull it back. So flexing those muscles all day from the loss of disc space and the flat back you have is another source of back pain. Spinal stenosis can cause back pain. So in terms of getting your back pain better, that's usually the number one mission is you have to diagnose it first because it's what's causing your pain. Is it this disc, this disc, this disc, these joints on the left, these joints on the right? Is it all of them? And that's why it's hard when people are like, I can't get my back pain better because sometimes it really is hard to diagnose exactly what it is. And, it's not like it's 100% here. Maybe it's 80% here, 10% here, 10% here. I know I'm out of percentages, but 10% here. So it's tough sometimes to just fix back pain. I tell patients all the time when they're seeing me, when I'm talking to them for their telemed appointments, when they have when they're like, oh, my back hurts a little bit, it's the shooting down leg pain, shooting down arm pain. That's what spine surgeons love to hear, not because patients get better from it, which I guess is why we love to hear it, but because we know how to diagnose it. We're able to use MRI, an exam, as well as injections at time to perfectly diagnose which of those nerves have the stenosis. And that's a big deal in terms of getting the patient better. So shooting pain, arms, legs, down the butt is great. Back pain, that's tough because again, it's sometimes hard to know what's causing your back pain. From Jackson, is it normal to have pain after a TLIF? It isn't normal, but it's definitely common. Normal means like it's expected. The TLIF takes out this facet joint and you put in one of these cages from the back, almost in this disc space like here, and you're just manipulating, moving those nerves all the time to put in that cage. And so that's why some people favor lateral surgeries or ALIF surgeries, going in through the belly, putting one of these fat cages through the belly, because you don't have to necessarily mess and physically manipulate those nerves. So is it normal to have that pain after a TLIF? No, but is it common? It's something called radiculitis after a TLIF surgery. Yes, it's definitely common. Let me kind of get some more things and some more questions. So in terms of from Wayne asking a very specific question, L5 ALIF or spondylolisthesis with a plate, should that be okay? It should be okay to plate spondylolisthesis, but probably the gold standard is having screws to back it up. If it's isthmic, if it's from a pars fracture, I don't know if I'd say it's okay. It's more likely than not going to work, but the failure rate of just plating isthmic spondylolisthesis, I think is around 30%. So should it be okay? Meaning, more than 50% chance it's okay. Yes. But the screws in the back are not that much more detrimental just in terms of the aspect of having surgery. If it was me or if it was my patient, I would do it. Now there could be a certain exception, like maybe it's like subtle, like very subtle spondy, but then like why are you doing a fusion would also be the argument if you don't have spondy. So not to get too technical or not to kind of be put on the record for it. It just varies, but it should be okay, but I wouldn't do it. How about that? Get to a couple other questions here. Sorry, so many questions coming in from Wayne Elder. Can back surgery issues prevent hip surgery? I don't know. I have to think about that. Maybe, but probably not. Is surgery the only option for spondylolisthesis? No. I mean, you don't have to do anything, right? Like just because you have a condition, even if you have severe spinal stenosis, you don't have to do surgery. It's all about how you're doing. If you just happen to find it on an MRI and you're doing fine, then don't worry about it. I know many people, even family members, that have really tight nerves on MRI and they're doing fantastic. So you don't have to do surgery. You don't even have to do treatment. From Wayne, already have screws at 3, 4, and 5. Look, I don't want to get into specifics, but if you're already fused above, that's way too much stress to be relying on that plate, Wayne. I don't love it, but I don't really want to give formal advice on your case just from texting here. I'm happy to reach out for a formal appointment. Do them all the time. Maybe I don't even want to say the number on a recorded line, but I do many, and happy to talk to you, Wayne. Um, but I can't give specific advice, my good sir. You could obviously understand why. So we get to a couple other things. Someone tell me about robotic spine surgery. Look, I like robotic spine surgery. It's a fantastic way to do certain surgeries, but essentially, whenever we're doing robotic spine surgery, it's just assisting with fusions. Now, that might change by the time someone watches this video in a couple of years from now, as these videos are out there and what did I just kick? Live forever. But this is what they do. They place these pedicle screws. They place these pedicle screws through the pedicle. Not a good model to show it. Actually, I have a great model to show it. Ah, you know what? It's inside. No, you don't have to go get it. But it's robotic spine surgery is great. It provides me extra safety. It provides me extra accuracy and provides me extra efficiency in the OR. But I don't need it in every case. And I don't do it on every case. For instance, I don't do it on neck cases, cervical cases. Not too common there. You don't need it on we don't really need it on any case, but I always use navigation pretty much for all of my spine surgeries in terms of bringing in a CT or something similar to a CT, putting on a helmet or using a screen like robotic spine surgery to help navigate these screws. Instead of relying on the X-ray tech or an X-ray specialist to be shooting X-rays to show me where my screws are, I can rely on myself. I can rely on your own anatomy. I don't have to rely on the X-ray being totally straight or curved or like that. I mean, you don't want it like that. You want it totally straight. In fact, if you're a little off and I'm using navigation, then I know, there's no straight up and down or using navigation. It's just perfectly in that spot, if that kind of makes sense. So that's why I like using navigation. That's why I like using 3D technology. Where am I located? Dallas, Texas. Do I do appointments? Of course. The number one reason people don't get their appointments scheduled or it doesn't get worked out is they don't have their own x-rays. They have MRIs because, you go to an imaging center, you need to have your own MRI, but not x-rays. There was, but having your own x-rays, just mailing them in the mail is a good way. You can also go to a CVS to upload it. If you go to the top of my website, I don't know why I'm pointing. We're not on my website, but if you go to the top of my website and look at that, it kind of gives you the information that's on donnellyspine.com, but I don't want this really to be a marketing for me or anything like that. So appreciate the likes, appreciate the shares. I'm probably going to stay on here for another 5 or 10 minutes and we'll go there. Amber, is that too long? 2 minutes. Okay. I can't tell. Someone's trying to ask me to. Good. Thoughts on cervical stenosis, kyphosis in children? Ooh. My thoughts, it's bad, but it's usually an underlying congenital thing. Tethered spinal cord detethering, will it reattach or new tethers form? No, not usually. Have herniated disc at up 4-5 causing a lot of pain. I have CRPS. I'm scared. Yeah, CRPS is tough. A couple of questions. How do I stop sciatic pain? I can barely walk. I'll usually doing planking exercises is a good way to kind of help focus on the nerves and the muscles in the back. Icing that area, anti-inflammatories are good. If you can have a doctor call in a certain medication, I'm not giving advice at all in terms of what medication, but for my patients that I've seen and I've diagnosed, I usually call in something called a Medrol steroid dose pack. And for my patients that I call in, I think those are very helpful to help with sciatic pain. I then start them on hopefully a 6-week course of formal physical therapy. I'm even okay with certain chiropractic therapy, and I partner up with different chiropractic doctors here in the Dallas area that I trust and that I know. Um, and then I also target with pain management specialists to do certain type of injections of those nerves. You'd be surprised. I probably know about 40 pain management doctors now, not in Dallas, not even in Texas, just because I'll get a patient from Reno, and then I text my buddy in Reno who's a good pain doctor, and I send it to them. And Winter Park, Florida, in Long Island. So I've actually made a huge network of friends being like, hey, you don't know me, but I'd like to send a patient to you. Here's the injection. And then in a HIPAA secure platform, I'll send them the referral over. But either way, just partnering up with different doctors. From Sancha, thoughts on disc replacements versus fusions. They're both extremely good options. I think the biggest problem, I have a disc replacement right here. Just to be clear, the biggest problem with disc replacements is that because people think they're so great, they are afraid to get a fusion when a fusion is the gold standard for their pathology. So let me say that one more time. I do love disc replacements. I do disc replacements. I support disc replacements. But the biggest problem is that patients are so blinded, understandably, by the thought that they only need a disc replacement. And so they'll delay care by asking 4 or 5 different doctors for a disc replacement. And then they finally find someone who's going to do it. And then they get the surgery that maybe others thought that they shouldn't. Any doctor can do, any spine surgeon can do a disc replacement whenever they want in a way, but that doesn't mean it's the best for your pathology. If you have too much disc collapse, if you have too much axial pain and certain other factors that are on your imaging, then you shouldn't do a disc replacement. So I have patients all the time that travel across the country to see me wanting a disc replacement, and I have to tell them how a 1 or 2 level neck fusion is going to be the gold standard to get them better. And a lot of times, that's a majority. They're like, okay, I understand now why, but I just want to hear it from you. And then we proceed forward, at a subsequent date. But my thoughts on disc replacements are that they're good, but they're not like perfect. You still have additional spine surgeries in the future just because you have the normal wear and tear. You have the normal degeneration of the other disc. You still have the risk and cost associated with surgery. You still have the return to work issues with either. So I like disc replacements when we can do them. I like them in the neck a lot more than the back. In the back, I don't love lumbar disc replacements in the back, but usually if I think someone is a candidate, I'll send them to my colleague, Dr. AJ Rush. He's in my group. I'd say he's my best friend, but I want that to be recorded. But what? Oh, sounds like we have to go then. Okay, well, on that note, I do have to go. Appreciate everyone jumping in, but yeah, I like to jump on here for about 20 minutes at a time. I'm going to end this feed right here. I'll keep this feed going for a couple minutes because on this feed, I'll give advice on other doctors in your area. I don't do it on this feed because I don't want it to be recorded, but I thank everyone. Look, go ahead and subscribe, follow, turn on alerts. I jump on here usually every Saturday, Sunday. I'll try to get to your question. If I don't get to your question, I apologize to the different cameras and platforms I have. There's about 1,000 people, a lot of questions. In the 30 minutes I do this, there's usually 8,000 people to 15,000. So I do apologize if I don't get to your question. My little plug is I'm in Dallas, Texas. If you have your x-rays on a CD and MRI on a CD, that's the best way to get in touch with me. You can reach out to our office, and I look forward to talking with you. You want to get a little shout out? Come on. Come on. Come on. Oh, someone's so embarrassed. Here's little Jack. He has been so patiently behind. You can look right there. You say hi.
Hey,
All right. We got to go. Thanks, everybody.
bye.
Okay, but I'm still going on this one, Jack.